Welcome to The Explainer. Today, we're going to break down the Varicella-Zoster virus, or VZV. Now, this is the single virus behind two totally different diseases you've definitely heard of, chickenpox and shingles.
Okay, so let's jump right in. VZV has this really fascinating double life. When you first get it, usually when you're a kid, it causes chickenpox. But here's the kicker. The virus never actually leaves your body. Nope, it just goes into hiding in your nervous system and can wake up decades later to cause shingles.
So here's the game plan for this explainer. We're going to follow the entire story of this virus. First, we'll get to know the virus itself. Then, we'll see how it causes chickenpox. After that, we'll uncover how it hides and then comes back as shingles, look at some really high-stakes situations for certain patients, and finally, we'll go through the playbook for diagnosis and treatment.
All right, let's kick things off by meeting the culprit itself. Because to really understand the two diseases, you've got to understand the virus's basic identity and, well, its family history.
So, what are we looking at here? Well, VZV's official name is human herpes virus 3, which puts it right in the herpes virus family. And like its relatives, it's got an envelope, that classic icosahedral shape, and it carries its genetic code as double-stranded DNA. And that family trait, the ability to establish a lifelong dormant infection, is absolutely central to its whole story.
Okay, now that we know who we're dealing with, let's move on to the virus's first big act, the primary infection, chickenpox. The clinical name is varicella, and this is its first all-out attack on the body.
You know, the way this virus moves through the body is actually pretty clever. It gets in when you breathe it in, multiplies, and then it basically catches a ride in your bloodstream, we call that viremia, to get to its main destination, your skin. And after it causes that classic rash, it doesn't just disappear. Instead, it pulls back, retreats up your nerves, and sets up a permanent hiding spot in the dorsal root ganglia, where it'll stay dormant for the rest of your life.
So, when the virus hits the skin, it creates one of the most recognizable rashes out there. But what exactly makes the chickenpox rash so distinct? Well, there are three classic features that every doctor is trained to look for.
All right, so the diagnosis really comes down to these three key signs. First, the rash is centripetal. That just means it starts on the trunk, the chest, back, and stomach, and then spreads out. Second, and this is a huge diagnostic clue, it's pleomorphic. This means you see lesions in all stages of healing at the same time. You'll see new spots, blisters, and old scabs all in the same area. And finally, the rash appears in waves or crops, and each new wave usually brings a new fever with it.
Now, even though we think of chickenpox as a pretty mild childhood illness, you have to be aware of the complications, because they can be serious. The most common one is a secondary bacterial skin infection, usually just from scratching all those itchy spots. But the most serious complication is varicella pneumonia, which is a much bigger risk for adults. And here's a critical point for exams and for practice. Never, ever give aspirin to a child with chickenpox. It's linked to a really dangerous condition called Ray's syndrome.
But remember, that virus isn't gone. It's just hiding. Years or even decades later, it can wake up. And this reactivation isn't just chickenpox part 2. It is a completely different disease called shingles or herpes zoster.
So how does this happen? Well, it goes right back to that latency we talked about. Think of the virus as a sleeper agent. When your immune system gets a little weaker, maybe from age, stress, or another illness, the dormant virus reactivates in that nerve ganglion and travels right back down the nerve to the patch of skin that nerve is connected to.
Clinically, the shingles rash is the polar opposite of chickenpox. It is strictly unilateral, which means it stops dead at the midline of the body. It doesn't cross over. It also follows a dermatomal pattern, perfectly mapping out the territory of a single nerve. And get this, the rash often isn't even the first sign. A lot of the time, it starts with an intense, burning nerve pain in that area for days before any spots show up.
And this is where shingles can get really, really nasty. The real danger often isn't the rash itself, but what comes after. The most common complication by far is postherpetic neuralgia. That's a debilitating nerve pain that can last for months or even years after the rash is gone. Other serious problems include Ramsay-Hunt syndrome, which can cause facial paralysis, and zoster ophthalmicus, which is a sight-threatening emergency if the virus reactivates in the nerve that supplies the eye.
Okay, let's shift gears to some really high-stakes scenarios. This virus becomes especially dangerous in certain high-risk situations, and there's no better example of this than during pregnancy and right after birth. The timing of the infection is everything.
It is absolutely critical to know the difference between these two scenarios because they are not the same thing. An infection early in pregnancy can directly harm the developing fetus, and that causes congenital varicella syndrome. But an infection right around the time of delivery,
that poses a different but just as severe threat to the newborn.
So let's say a mother who's never had chickenpox gets it for the first time during her first or early second trimester. Well, there's about a 2% chance the virus can cross the placenta and infect the fetus. This can cause congenital varicella syndrome, which is just a devastating condition. We're talking scarring skin lesions, underdeveloped limbs, and serious neurological damage.
Now, this second scenario, neonatal varicella, is a true medical emergency. If the mother develops her rash right around the time she gives birth, the baby gets exposed to the virus without getting any of the protective antibodies from her. There just wasn't enough time for them to transfer. This leads to a severe, widespread infection in the newborn with a mortality rate that can be over 30%.
So with all these serious possibilities on the table, how do we actually lock in a VZV diagnosis? And more importantly, what's the playbook for managing it?
Well, a lot of the time, the clinical picture is a dead giveaway, but one of the classic lab tests you'll hear about is the Zank smear. For this, you basically scrape the bottom of a blister, put it on a slide, stain it, and look for the classic signs of a herpes virus infection, specifically these things called multinucleated giant cells. But, and this is a huge but, you absolutely have to remember that Tack smear has a major limitation. A positive result confirms you're dealing with a herpes virus, but it can't tell you which one. It looks the same for VZV and for herpes simplex virus. So, to tell them apart, you need a more specific test, like a PCR.
When it comes to treatment, the go-to drugs are antivirals, like acyclovir. And the real goal here isn't just to make the rash go away faster, it's to prevent those serious complications we talked about. And because VSV is incredibly contagious, anyone with it in a hospital needs to be on strict airborne and contact precautions until every single last spot has crusted over.
But you know what they say, an ounce of prevention is worth a pound of cure. And thankfully for VZV, we have a really powerful two-pronged approach. We can either stimulate the body's own immunity, or we can provide a temporary borrowed defense.
Think of it this way. On one side, you've got active immunization with the vaccine. That's like training your body's own army to recognize and fight VZV. On the other side, you've got passive immunization with something called VZIG, Varicella-Zoster immunoglobulin. That's like calling in temporary reinforcements when you're under attack.
Now, it's really important to get this straight. VZIG is not a vaccine for just anyone. It's a post-exposure rescue mission. It's saved for high-risk people who've been exposed to the virus and can't get a live vaccine. We're talking about people who are immunocompromised, pregnant women who aren't immune, and those very specific high-risk newborns we just discussed. And that's our breakdown of the Varicella-Zoster virus, a single agent with two very different clinical stories. We followed its path from the itch of chickenpox to the nerve pain of shingles, and we've covered how we can diagnose, treat, and ultimately prevent its impact. If you like this video, then please like, comment, and subscribe.